Okay, should we start? All right, ladies and gentlemen, welcome to the last session. I'm sure you're looking forward to it with great enthusiasm to go and celebrate the evening. My name is Shiv Kumar. I'm an economist and a policy advisor. In many ways, it's a logical conclusion to the day's proceedings because we'll be talking about results and outcome-based financing. And given the topic of this gathering, it's also one of the most relevant sessions for policymakers, administrators, and people from the Ministry of Finance. It's very nice to see Mr. Sumit Bose back again. Several key aspects of results-based financing have been flagged in the previous sessions, and I just wanted to touch on some of them which might come up again in the presentations and discussions today, later in the session. First is, I think, what should be the components of some kind of an essential ECCD package is something that we have to keep in mind when we're talking about results and outcomes. There was, in terms of the services, both direct services and complementary services, in terms of staffing, in terms of resource requirements, particularly in terms of standards. This has been a question that has been raised, and very important to keep that in mind when we are accounting for results. Second, the adequacy of public financing. And in fact, having adequate public financing is a prerequisite for discussing results-based outcomes. Because from what we have heard in the morning, despite the significant increases in allocations, all these sectors, basic education, health, nutrition, remain seriously underfinanced in India and elsewhere. And this underfinancing by the state is both a cause and a contributing factor to high inequities, unequal access, poor reach, neglect of special needs that was highlighted, and the poor quality of services. Equally important, I think another issue that came up has to do with the efficiency of spending. So it's not only about allocations, but also efficiency, and some of the discussions highlighted the need for systems reforms or institutional mechanisms that will reduce leakage, wastage, and improve efficiency. Building on this, we are now going to focus perhaps on results and outcomes, and we are looking forward to the presentations, both the short-term and the long-term outcomes. We need to have a clearer sense in terms of monitoring and tracking performance. Both budget is one side of it, monitoring and tracking of budget and public expenditures, but equally the task of linking these expenditures to outputs and outcomes, both immediately for improving performance, but also to track improvements in the system. And this brings me to the last point before I invite our presenters. When we're talking about outcomes and results-based financing, we are also at the back of our mind looking at how to improve outcomes and improve results, which means that we need to really focus a lot on evaluation. Evaluation, both dimensions of evaluation, looking at systematic evaluations to see what are the lessons learned so that we constantly improve the quality of service provisioning, and also the accountability aspects of it. And again, a question that came up, who is really responsible and accountable for outcomes, and how do we drive better performance in the public systems? So we have had a flavor of all these different ideas in the sessions that we have had so far, and today we have two presentations. One by Chris Desmond from HSRC South Africa. Chris, I'd request you to go first. And the second one is by Ashrafi Ahmad, who is the Deputy Program Manager, Hospital Services Management, Directorate General of Health Services, Bangladesh. After Chris. So 7 minutes each is as we do. Thank you.
So good afternoon. Before I start, I should comment that, I like working in the children's sector because it has got so many nice people. Nice people are attracted to working on issues related to children. But wait. There's a reason I don't like working in the children's sector, and that's because there are so many nice people in the children's sector. And the problem with that is that nice people don't like to make difficult decisions. And when you get to priority setting and to looking at which outcomes are important, the children's sector is an absolute nightmare. boil anything down to say this is the essential package, and someone will put up the hand, well, you've forgotten so-and-so, you've forgotten these people, you've forgotten that outcome, you've forgotten this, you've forgotten that, and we're back to everything. We're never able to say, this is where we're going to start. We're brilliant at defining some utopia that we would like to reach one day. We're very bad at saying whether taking road A or road B is getting us there faster. We just want to get to the end all in one step. So what I want to talk about, and what links us somewhat into the discussion about the outcomes, is to talk about what is appropriate to consider when trying to set those priorities. What should be in the discussion? And we're going to try very hard to keep to the 7 minutes, although this clock seems very fast. It went from 7 to 5 in an incredible short amount of time. Particularly because I've been making jokes about how increasingly during people's presentations they lean this way, and so they don't see the timekeeper with the thing there. So in keeping with that spirit, I just want to make 3 points. I want to say that we should evaluate sets of interventions, and it's a big problem when we start evaluating interventions on their own, and that we need to look at a vector of outcomes, by which I mean many outcomes. We can't just look at one thing, and that we should consider whether or not framing does or should make a difference. So why is it important to look at sets of actions, or sets of interventions? So, you know, we've talked a lot about how child development involves many different parts, many different things, many different inputs. But sometimes we talk about it as if it's a production line. You know, we can put one thing in now, we don't need to worry about it, we can come back later and add the next bit on. But that's not how child development works. It's much more like, you know, sort of a bakery. You have to put lots of things in together in order for them to work. You can't come back later and add. Once all the pieces are in, they need to work together, and they need to be balanced when they're working together. There's no point in putting more and more and more of one ingredient in without the other complementary ingredients to go with it. Except I will disagree with the speaker from earlier, except when it's cash, because that can buy other ingredients. So, but we have to also think about how context matters, and so how we need to think of what is the set of interventions that works. Otherwise, we can lead to very inequitable outcomes. If we look at evaluating interventions for certain groups of people who have other services already in place, they will interact and they will end up getting better outcomes than the children without the services. So, for example, if we looked at early childhood development centers and we said, let's evaluate those outcomes, the children who go on to have better access to school and better access to secondary school and better access to university will have better outcomes from that investment in early childhood development because they have those other services already in place. So we'd end up prioritizing those children. If we said, let's evaluate a set which includes the early childhood development services and a better primary school and a better secondary school, then suddenly we see resources shifting towards those children who have less. So evaluating a set makes a great deal of difference in evaluating interventions on their own, and that goes for within ECD. If we evaluate nutrition for children who have access to good school, we get better educational outcomes. So the vector of outcomes. We sometimes try and boil it down to what is the outcome that we can maximize, what is the single outcome that we want to do, and there's lots of this sort of results-based efforts to try and really narrow it down, and that's where we get the sort of cost-effectiveness approach. But cost-effectiveness is extremely narrow. It allows us to talk about only one set of outcomes and will invariably lead to interventions which focus on that small set of outcomes. So we end up with vertical programs. It's no accident that if we have an evaluative framework which concentrates on a small set of outcomes, that we will have interventions which target those. Those which target broader sets of interventions, again, like cash transfers, like family support, are often not seen as valuable because they don't target the individual outcome which someone is focusing on. We can look at cost-benefit analysis type approaches where we say, let's include everything, but let's put a monetary value on that. That's extremely controversial because you often have to put monetary values on things like, you know, what is the value of not being stunted? What is the value of being alive? What is the value of having equal access to education? It's very controversial to do those sorts of things. So we have developed an approach which we call the cost of inaction framework, which we have a book on which takes a little bit more than 7 minutes to read. My colleague and I, Sudhir Nunn, looked at this and we were asking how can we evaluate interventions in a more holistic manner. And we there wanted to talk about the full range of benefits, putting together a vector of benefits to say what are all the outcomes, can we quantify them, can we monetarize them, can we even just describe them and lay that out and say that is the framework, that is the full informational frame in which you should be making decisions. But that doesn't allow you to rank interventions, and people like to rank interventions. And so because of that, it's not necessarily a popular approach because people, or even policymakers sometimes want to be told, well, this is what you should do. They don't want to go through the hard process of making those value judgments judgments. But we have to then sit back and ask very carefully who should be making those value judgments and how. There is no mechanical way to choose what should be done first in providing ECD services. There just simply isn't. And we have to make those value judgments, and we need to bring them out into the open rather than hiding them away and trying to make them appear like an economic technical exercise. Because otherwise you'll end up getting the values of economists. I'm not sure you really want those. So framing. When we did this, we talked a lot about, when we say there's a cost of inaction, we should be clear that you have to have an action that was not taken for there to be a cost of inaction. So essentially, we started discussion about how one evaluates an intervention. That's how I can make the comparisons to cost effectiveness or cost-benefit analysis. Now, when you do that, you can then start talking about what are the benefits of actions. What are the benefits of early childhood development that we should be talking about? Now, that's exactly the same from a conceptual point of view as talking about the cost of inaction. What are the benefits you lose from not doing something? So from a theoretical point of view, it should make no difference. But we have discovered that the way in which you frame a case to people does make a difference. Even when you frame exactly the same information, you put it in a different way. So when we say with early childhood development, you are missing out on all of these long-term benefits, all of these short-term benefits in all these multiple sectors, we may get one response. When we say, describe those exact same benefits and say, because you are failing to do something, we are suffering all of these consequences. You link that much more to a sin of commission. It's something you are doing, even if what you are doing is sitting on your hands. That it's something you have done which is leading to these outcomes. Even if it's the same thing, it makes a difference to the way in which policymakers may respond. So to keep to my 7 minutes, as it bleeps, there are my 3 points as a reminder. Thank you very much.
Good afternoon, ladies and gentlemen. As you can see, both my names, my surname and last name starts with A. But unfortunately, I'm the last speaker of today. So I hope I can keep you amused or bored, whatever. So greetings from Bangladesh, and I bring a tremendous success story. Our under 5 mortality rates have demonstrated a steady decline, and we have truly we are on our way, on our path to achieve the MDGs, and which you already know. But what we found out that the rates of neurodevelopmental disorders, which include neurodevelopmental impairments and disabilities, are considered together as a part of the continuum, and it has been increasing. The reason still has to be researched, but what we are thinking that they were, undiagnosed, or sort of the children with these delays in development were unrecognized for some reason, because our society, is burdened with all types of illnesses and other social pressures. So this area was sort of neglected. So to address this, we have incorporated in our health program. Our health programs are now divided into operational plans. There are 19 operational plans which are being run, and these are the Bangladesh budget system has revenue and development part, and these the operational plans are under the development budget, which is from the mostly funded by the donor pool fund. So we have with these donor funds we have already established 15 Shishu Bikash Kendra, that is child development centers. So, so I have already told you about the background. So 15 Shishu Bikash Kendras or child development centers are now fully functional in our government medical college hospitals. Before, it was never even thought of, and this is such a new idea. And what makes it unique is what should I say, pioneered by Professor Naila Zaman Khan. She's a leading lady in this sector. Many of you know her, and I'm just representing her work. She did a tremendous job. She's working as the national coordinator. Although she's from a private organization, but this is a very unique program from Bangladesh. We have given her the liberty to be the national coordinator of this unique program. So how it is run, there is a multidisciplinary team in each of the Shishu Bikash Kendras. I invite you to please visit these centers when you can. And they have a child health physician, child psychologist, developmental therapist. This is a team. And also support staff, office managers and cleaners and computer operators. And the specific clinics, those of you who are working with children with development delay, you know that these are the clinics that are being run. So this is very unique. I mean, and they are such a very devoted team, and they're working free of, these centers are being run free of cost. And the outcomes are, we have till June 2014, 110,000 attendances. These attendances would have been more, but we have to control because time limitation, government hospitals run till 2 p.m. and also we have to ensure quality. And the children screen, high risk, they are bought from the other wards also, and the survey has been done, which is very unique. You can find this in this website of our DG Health. And we are placing undergraduate and postgraduate students in these centers because they were not at all motivated about this aspect. And all services are free of cost. And we are also trying to set up in our tertiary level hospitals are doing it, but we are at the primary level hospital also we will set some satellite clinics. So what I want to share is the way forward. This has been a great success story. The CDCs are working well, and we are planning to set up in future 2 district hospitals, which are our secondary tier hospitals, so that this is more community-based mandate, and networking should be done. Home visits with assistance of the social worker of each hospital is also being planned. And more or less we have to do it home-based screening. And here is what I want to say is that although we are running this project, there is a severe delay in fund release. Like there are some constraints. This is called reimbursable project aid. We have to reimburse the fund after we spend it. So it takes long time to release the funds. Like our team, they are not paid for their July wage, they have to wait till September. So we are asking for more funding authorities to come up so that this can be run with direct project aid. So so as I invite you to just look into our website and see whatever we can do, because the outcome-based financing is here you can see the result very directly. And so with that I end my presentation. Thank you.
Thank you, Lucy. Time to open it up, first for our members and afterwards for everybody else. The discussion could go in different directions. I mean, you suggested one, cash or no cash. Another one, the level of development of a country can be very different in different countries. So please, any question to the 2 presenters? Benita.
Yeah, my question is to Amarjeet. It's basically not to do with cash transfers, but to do with the integrated platform that he was talking about. Would it be, how would you react to this statement that it makes sense to integrate at the level of planning and monitoring, and the implementation can be sectoral?
We'll take a few other questions and then, please.
Hi, these were great. These were great. I guess my questions are for Lucy, whether you could talk more both from your research and other research about how much we know about the time sequencing of impact. So how well do we know? I get your major point about the need for it to continue, but is there any impact from early? How big is the advantage of early? Is there any impact from late with no early? Can you just walk us through the evidence on timing?
Thank you for the question, Vinita. It's not an issue of planning, monitoring and implementation being looked at separately. Let me give you a very concrete example. For example, once the Cabinet Committee on Human Development adopted 18 indicators, for each indicator, there was a series of process indicators as also final outcomes. Now, once the detailed activities which are likely to contribute to that outcome was broken up, naturally, there were various departments which had responsibilities. But the benefit is, once it has the approval of a state cabinet, then, for example, we have launched on the 15th of August our program for 0 to 3, the Bal Kuposhan Mukt Bihar program. Seeking the interventions of health department or labor department or education department becomes much easier after that. Because what is clearly accepted as state priority is these 18 indicators and whatever contributes to the achievement of those outcomes. So this distinction of planning, monitoring, implementation is not there. Resources are departmental. Resources for, say, immunization will not get transferred to social welfare, it will remain with health. But what will happen is the institutional arrangements. For example, under the Rural Health Mission, they do the monthly Village Health and Nutrition Day. Now, what is it that the social welfare will do that day? What is it that the health department will do that day? So the platforms are common, the budgets are separate, but planning, monitoring, implementation, everything is together. In the sense that they are held accountable for that activity across sectors, and once the cabinet has approved the entire plan, then nobody can say that we are not a part to it. We are very much a part to it. You'll have to provide your interventions.
Thank you. It's a good and difficult question. In terms of HIV risk, we're still really early days with this research. There's only about 3 or 4 studies available in the world. What we do know from Kenya introduced an OBT cash transfer program, and quite recently, and they did find impacts of that in a sort of randomized cluster trial on HIV risk behavior. And also in Malawi and in Zomba, they did a randomized trial and found they compared conditional and unconditional cash transfers on teenage girls' HIV risk and HIV incidence. They found no difference between the conditional and unconditional. Both seem to work. So there is some evidence that receiving cash transfers, at least in adolescence, does seem to work for that. But what we don't know about really is day stuff, and whether receiving these provisions food care in that at an earlier stage, which then might stop, would have a long-term impact. And actually, this reminds me of a lecture that Larry gave, Larry Aber, in Oxford 10 years ago, and he might know this much better than me from the evidence from America, Larry, whether early provision of these kinds of programs has long-term impacts even if it stops early. Sorry, Larry.
10 years ago, I'm forgetting. I will say that we did I don't think the evidence is strong because there's not a lot of longitudinal evaluations following non-health, non-education outcomes, following mental and behavioral health outcomes. But on the theme of mental and behavioral health outcomes of conditional cash transfers, we did a CCT trial in New York City, and the conditional cash transfers did not improve. It improved the amount of time children spent on school, on academic-related activities. It did not improve their outcomes, their academic outcomes. And this is consistent with the notion that if the institution isn't rich enough, the cash isn't going to make the difference, even if they spend more time. It did reduce adolescent substance use, adolescent aggression, and the substance use levels of their peers. And those substance use prevention effects were as big as substance abuse prevention programs. So the cross-sectoral impact, I think, is really considered in this sector. So that was a half an answer to half the question.
Okay, please.
Yes, I have a question for Mr. Sinha regarding your indicators and how the research was conducted, because it's very impressive that that was done during the planning stages of the intervention, and so there is more of a focus then on looking at those indicators that were determined. Did you have a relationship with researchers at a university for that, or were there people within the government that were organizing that? And then are these results published, and is the methodology described so that other states can learn from your example and benefit from what you've learned? Thank you.
Thank you. My question is for Lucy. Thank you very much for your presentation. I wanted to know if you had the chance to cost the care component, and also if there is any information about the impact on reducing violence. Thanks.
So before taking questions at the back, we'll let you answer these two questions, and then we'll move to you.
Thank you, Vesta, for your question. The background to it, let me begin. The idea of setting up of the Cabinet Committee on Human Development arose because the Chief Minister of a state had to sit in 40 different committees. Literacy had a different committee, ICDS had a different committee, SSA had a different committee, till finally one day the Chief Minister says, I am not able to effectively contribute to any of them. So what do we do? It was in this context that a Cabinet Committee on Human Development was thought through, because they're all interrelated in terms of their effectiveness also. The first action was 18 departments were roped in. Departments responsible for decentralization, for water, for sanitation, for education, for health, for the welfare of scheduled castes and scheduled tribes, for the welfare of other backward castes, urban development. And all these departments were asked to make their presentations before the Cabinet Committee on if we have to achieve the Millennium Development Goals, what is it that every department in the state will have to do. So the backdrop was the Millennium Development Goals. If these have to be achieved by the state, what is it that you'll have to do? After those series of department-specific presentations, 18 departments were reconstituted in committees, in 7 different committees. Committee on Education, like that, 7 different committees where subject matter was collapsed and brought together, with academics also as members. Each committee was given about 3 months' time, look at all the evidence and the data, and then submit the report in the same committee, the Cabinet Committee on Human Development. So from 18 departments, 7 subcommittees, 7 subcommittees having evidence-based inputs from academics and others, submitting a report, those reports again being presented to a Cabinet Committee, again certain suggestions, till finally the draft document is ready, where these have been defined and accepted as the state government's priorities. So I hope I am able to clarify the point that you had.
Great. These are 2 great questions, and actually very similar to the ones your UNICEF colleagues at HQ have been asking. So clearly UNICEF does speak with one voice. Costing the care component is something that, as we've been talking to policymakers in sub-Saharan Africa and up towards West Africa, they've been repeatedly saying. And we sort of thought that they would be very suspicious of the evidence, and instead they said, okay, great, how much is it going to cost us? And I think what's really important here is to think not just about how much do these cost, these kinds of interventions, or making these things happen cost, but also where do those budgets come from? And Charlotte Watts and her team at the London School of Hygiene have done some excellent work looking at a sort of bucket funding approach and showing that they look at cash transfers, and they show that with the multiple outcomes, if the Department of Health put in some, if the HIV budget puts in some, if the Department of Education puts in some, that they can all benefit from the outcomes but not have to have their entire budget vanish on these one interventions. And I think we're early days with that, but it's completely essential. The question on violence is harder, and I assume you're talking about child abuse and violence, yeah. So violence is a very, very clear pathway. So for example, we see that children in an AIDS-affected family have 3 times the rates of sexual abuse, physical abuse, emotional abuse, and domestic violence than children in a non-affected family. We then see that children, for example, who are sexually abused have a 12 times the odds of having transactional sex. So it's a very clear and essential pathway in this route to risk. But it doesn't seem so clear what cash and care are doing here. They certainly mitigate the pathways, they mitigate the impacts of experiencing violence. But cash alone is clearly not enough to reduce the risk of abuse happening in the first place. And something that we're trying with WHO and UNICEF, we're actually doing a parenting support program, a free parenting support program for sub-Saharan Africa that may incorporate a sort of financial component to see whether the combination really works better. That's going to mean a 3-arm randomized control trial, which keeps me awake at night. So we're going to try, though.
We'll take questions from the back. Yes?
So under the NFSA, there's a provision for providing a cash transfer in lieu of food in case a state is unable to deliver the food subsidy that the beneficiaries are entitled to. And we've calculated that the maximum expansion in coverage is for UP and Bihar. I just wanted to get your views on how do you think the provisional cash transfer can play a role in providing more food security, if not also have other spillover effects as well?
I am Neerja Sharma from University of Delhi, Lady Urban College. My question is to Lucy. Could you expand a little bit on the components of care for adolescents? That's all.
Yes, the lady in the middle. Yes, please.
Yeah, my question is to Mr. Sinha. On one hand, I appreciate the fact that you talked about care for children 6 months to 3 years. But what I want to ask you is that why do we still go on appreciating the fact that that immense work done by the caregiver needs to be, remunerated by just, not even a minimum wage and just 3,000 rupees? And why are we not taking cognizance, and why are some models of good practice still continuing to pay less than the minimum wage?
We'll take a few more. Yes, the row before.
Thank you for the wonderful sharing. I have a question for Mr. Sinha. The 18 indicators that you have talked about, does it include indicators for identifying disabilities, and what is the plan that Bihar is doing for that?
At the back there.
Mr. Sinha, I have a question on your demand-side financing, improving the accessibility. The supply-side financing has not helped in, do you think the conditional cash transfers for supply-side financing, do you have examples to say that it will help to improve outcomes? And if it will, then what kind of, focus on quality is important, I understand. And then what kind of methods do you see there so as to improve outcomes? Thank you.
And any other question?
Thank you very much. I'd like to show my appreciation for the explanation by Amarjit of the platforms. This is so brilliant. We found similar mechanisms in, for instance, Kenya and Peru in a study into the governance of ECD. And these coordination mechanisms allow you to coordinate, to create coherence, while keeping the delivery mechanisms and the funding distinct and transparent. And I think this is really an area that should explore more. Thank you.
So we'll let Amarjit respond. I think most of the questions were for you. Maybe there were a few for you. So please go ahead first.
I think the question on food security is the most difficult one. It's most difficult because ideally food again is something where the provision of food is more important than the money is to be able to buy it. especially assuming that what will be bought in the market is going to be more expensive than what will come through by way of provision. But having said that, a public system delivering food is a challenge by itself. The kind of crafting of an effective public system which requires is a big challenge by itself. And therefore, frankly, I have no clear answer to you. Unless we put in place a system which is leakage proof substantially, actual provision of food will remain a distant dream even if you don't go for cash transfers. So I think clearly programs of this kind, my personal view is, they need far more preparation before we go for them. Unless and until we can actually provide for a system which can deliver what is expected. And I think this is something which applies to a large number of programs run by the government. The last mile planning is an afterthought, which to my mind is the biggest concern. Any program, if it has to succeed, the last mile has to be thought through very carefully. And again, I'd like to reiterate, at the cost of being repetitive, there is no going away from crafting credible public systems. Nowhere in the world has human development happened without credible public systems. Whether it is health or education, any of these sectors. Much as we welcome participation and partnerships with the non-governmental sector, there will the presence of a functional public system is the countervailing presence is very necessary even to determine the cost and quality of services provided by the private sector, especially sectors like health. The second issue with regard to the caregivers and the monies that they get, I just wanted to, one, at a personal level, I completely support the point that you've made. But again, just on the facts, the Anganwadi workers, if they get 3,000 rupees, what the governments have done is that the work allotted to them is only for 4 hours a day. It is not a full day's work. So therefore, technically, there is no violation of the Minimum Wages Act. Technically. I am using the word technically because effectively, to run an Anganwadi successfully, she needs to put in much more time. But the Phulwaris with the Jan Swasth Sahyog is running, they are providing 6,000 rupees to the, because those centers run from 10 o'clock to 4 o'clock. It's a 6-hour day care center which they provide for the 4 hours. Now, if, well, Anganwadi come creches are 6 hours, Anganwadis without creches are 4 hours. I mean, asked it. Anyway,
even there,
but having said that, I agree with the point that you are making, that there is a case for paying more, because these are all caregivers' jobs, and perhaps you may need more persons in a village, the kind of care, especially for 6 months to 36-month people, which is required. The issue of disability, yes, see, what has happened is, identification is really the biggest challenge. The census gives a certain figure for disability, but a large number of benefits for the differently able are based on certain defined criteria. For example, pensions, whole lot of other scholars, 40% as per a certain scale, 40% differently able, there is a certification process in many of those cases. So entitlements do not go to all those who are listed by the census. And the listing by the census is not the best arrangement available. So I think what needs to be done both for old age persons, widows, as also for the differently able, is what we are trying to do now, is to get an actual, because Anganwadi Sevikas are there in every village, every hamlet in fact, to be able to get that full picture through a non-technical arrangement first, and then to provide for the certification of the differently able, therefore to be able to design an intervention which works. So clearly much more work is required there, but on the differently able, I'd only like to say that here again, just the provision of 3 special educators in a block does not mean that the requirements of the differently able children are met. As an experiment 2 years ago, we started with our Kasturba Gandhi Balika Vidyalayas, which are there in every block. In about 100 of them, we decided that besides the 100 girls who enroll, we will have 25 differently able girls, visually impaired, orthopedically challenged, deaf. And what we find, the finest way of mainstreaming differently able children is to put them through a residential school like the Kasturba Gandhi Balika Vidyalayas. Mere provision of 3 special educators in a block is not the full answer. Clearly, we are not doing as much as we need to do for the differently able.
I'll be very brief. Just to say about the components of care. The way that we found our components of care was that we spoke to NGOs and government before we started the survey and said, what would you like us to include in terms of services for children? We did notice that some of the services that government and NGOs thought were very widespread were not actually accessing nearly as many children as they thought. But something that we're working on now is introducing these kinds of measures of care into other studies in Tanzania and UNICEF studies in Tanzania and Malawi and a World Bank study in Swaziland. And there, each country is thinking about what kind of care they provide. So, for example, Swaziland has after-school clubs and before-school clubs, and they're including that. So I would really... I'm not sure that South Africa's examples are the best ones to know. I think that this is really going to be different in every country, but really worth rigorously testing.
Thank you. I think we essentially have to close. We took a little bit less than 1 hour, but we started late. What I found really nice about your 2 presentations is that it's very hopeful. I mean, essentially, you gave messages of success in these planning committee as well as some of the programs you did in Bihar, and again the AIDS interventions with the cash transfers and the care really seem to work, at least to some extent, in South Africa. So a number of things are working, and this is a really great message. Before closing, Kimber did mention to me that we couldn't give the floor to everybody at the back, but there's a person who is available to take a small, quick interviews, 30 seconds, 1 minute. I don't know if that person can stand up. Right, there. So whether you are a forum member or whether you are at the back and there is something that you did want to say and were not able to, you can do it through these quick interviews, which are going to be made available on the website of the workshop at the forum. Thank you again to everybody.